Synthes, I think, still has, but used to have, an elite group of special forces. And we're really privileged to have one of the true giants for Synthes in terms of the special forces. So I've known Jim Green for over 25 years. He's been very helpful to all of the faculty members here. And Jim, in the early 90s, was the go-to guy to figure out for the surgeon how we could prevent problems, especially in nailing with the proximal tibial fracture, and then spent a good 20 years really developing and perfecting the principle of the RIA. So we're going to have a half-hour discussion, and Jim has a huge amount of expertise. And so Jim is, I think, if I think of the special forces from Synthes or even fracture care world, Jim's the leader of that, and we're really privileged to have him here. Jim?
Well, Phil, thank you so much for the introduction and the invitation from the chairman. I'd like to say kind of at the outset that I'm not a clinician, and I'm not a scientist, and I'm not an engineer. So you're going to be seeing a little bit more how somebody like a gumshoe, I guess you would say, puts a case together and tries to decide maybe what the company should do. In particular, this is a story that kind of needs to start with the beginning, which is the debate that was going on back in the 90s. And at that time, there was the concern that maybe early total care wasn't exactly the right thing to do for everyone. And this came about when Harold Cherney asked one of his students by the name of Chris Pape to take a look at the evidence from Hanover to see if there were any concerns. And it came about that maybe some of these people really were too sick, particularly those with chest trauma. And maybe they shouldn't get a ream nail at all. They should have an unreamed rod. That might be a way to get around some of the problems. And then they did a study that showed that maybe the AO reamers were actually the very worst of the reamers on the market out there. And of course, I was with the company that was distributing the AO reamers. So when at these major orthopedic meetings, an authority gets up and compares the AO reamers to toilet bowl plungers, which is really a pretty apt metaphor because essentially it's elegant and crude at the same time, and that is that the purpose of the toilet bowl plungers is to push crap into the system. So when the point is being made by an authority like Bob Winquist, it's motivational. So the question then, if that's the issue, what could be done to maybe solve it? And as you begin to go out and look into the literature, I was very lucky that a person by the name of Strumer had recently published all of his work that he had done in Davos. And this was in late '93. I don't think anybody ever really read the article, which was fortunate for me. But he has the title there, and it's a proposition to reduce the pressure increase with intramedullary reamers. And he goes about describing not only just what they have done and that they've been successful, he essentially gives the blueprint for what needs to be done because he's provided all of the essential variables and given them weight as to what needs to be considered in a redesign of a reamer. And the elegance of this has to do with the equation, and I'm not really a math person at all, but it's been taken from the oil and gas industry, and it's all about trying to get the maximum amount of throughput of a drill head. And the only part of that equation that's really wrong from our standpoint is this delta P. And for the people that are trying to get back something like water, oil, gas, whatever, they want to develop as much pressure in front of the drill head as they can get because that gives them ejection pressure. But for us, that would be exactly the wrong thing, because that's going to be a pressure that's going to want to broadcast the material all through the system. So instead of pushing the material out, we change the equation in one way, and that is we try and pull it back with suction. Otherwise, it's pretty much right on the mark. The other thing that the paper did was something I think that's sometimes overlooked, and that is it provided a bibliography. And the bibliography is so important, I believe, because it gives you an idea of the foundation that this person, who's now an authority on the subject, and how they came to that their opinion. And in that bibliography was this work by Dankvart Lillestrom. And it's really incredible. And if you want to see a historic piece of literature that is just really unbelievable, try and find this. It was such an important piece of work that the person that wrote the foreword for his thesis was Gerhard Kunschner. And Kunschner is saying that in 20 years that they've been doing reaming, nobody's studied it. So this was a study on bone healing as related to reaming that was being done at the very same time all the work was being done on bone with plates and screws and how they heal. And what he did was he took rabbits and he introduced a suction device through the medial malleolus and removed all the intermedullary content, or he did not. So there were two groups, a suction group and a no suction group. In the group that was in the suction group, not only had the catheter withdrawn all the intermedullary content, he then left it indwelling and then poured water through the entry portal and suctioned it out the bottom. And what he found was that the bone healed differently. If the fat had been broadcast through all the little canals of the bone, it didn't heal with a sort of almost primary bone union. And he felt that might be because of the fact that the fat was kind of degraded and left a toxic product behind, or it just occluded the mechanical opportunities for revascularization. But if they had removed all that content and they hadn't forced fat through the bone, they had a completely different sort of a healing. And he showed that in some of the x-rays. And he also was able to extract fat from a catheter in the femoral vein and then recover fat in the lung of the animals. You saw that there was a systemic effect, so that the group that had suction had no local infections, they had no deaths from fat emboli, whereas in the group that had no suction, they had those systemic issues. So I'm lucky now, I have two papers in my hand. One is essentially a blueprint that says what you need to do, and the other is a paper that says if you can do it, what your advantages might be. So with that, we came to this device. In that drawing, I did put in the idea of being able to capture the reaming material. My thought was we were going to encounter a sales objection, and that is that we were going to remove the grafting product, which many people think of a reamer as being an autografter, which is a little bit controversial. But so there was the idea that we did need to put in a method to be able to capture the reamings. So we had some evidence that the reamings were osteogenic, even though they came from reamer heads that look like this. And you've probably seen them. Their material's pretty much baked in there. You have to sometimes take an instrument to be able to get the material out of the reamer head. So this is an example, I think, of a paper that shows some what the word prescient's really all about. It's by one of the course chairman, Professor Johnson, who back in 1987 is talking about using reamings in some of these patients and the fact that they'd been able to see a real advantage. But the person that really took the idea of using the RIA as a way to accumulate bone graft when you didn't have to worry about intermedullary pressure was Tim Weber. And for those of you that know Tim, he's an incredibly modest person, As a matter of fact, I wonder if he didn't turn his name badge around just so that nobody could see his name, but I'd like to call him out as the person that really deserves to be recognized as the father of the entire technique. So you're literally seeing the very first RIA graft in his hand there, and he's pouring it from what was the strainer and I believe the sterilizer there. We didn't have any sort of way to really strain out the material, so that was the trap that we used. And in his very first case, this was in 2003, he puts in a spacer, and it did go on to have a good result, and even early on he could see that it looked as if it was headed in the right direction. And I asked him, I said, I wonder if this has anything to do not just with this RIA graft, but if it has anything to do with this spacer that's gone in there. Because I remembered a paper that was given by Kai Clowie at the OTA meeting in '96, and he described the study that they had done with sheep where they created the 4 groups, and that would be to put the PMMA spacer in there, cause the membrane, put graft in there, and then the other group where you take away the membrane but you put in the graft, you leave the membrane, or you put no graft, no membrane, no graft. And of course it was group A that did the best. Now at that time I knew Kai Clowie and I knew who Stefan Perron, but I didn't know who the other people were. This Mascalais, for instance, I thought was probably just a student up in Davos and managed to get his name on a paper, and we'd never ever hear about him again. But it didn't take me very long to come across his paper. And as you look at this and what he's dealing with and the results that he's getting, they're really pretty astounding. Enough so I'm kind of wondering, is this really true? So I thought, if possible, I'd really like to meet him and talk with him. And I had the opportunity, although my wife wasn't really sure why I should give up a vacation day in Paris to go out and talk to another doctor, she was gracious enough to encourage me. And I found that far from being a student at Davos, he was actually the chief of service at one of the large French hospitals. And he was just an incredibly gracious, kind, generous person. And he was quite willing to share his information and even these slides of some of his cases. And Tim and I worked them up into presentations and gave them to numerous audiences. And one of the things that I thought was very interesting about this membrane is how did he come to really kind of recognizing and doing this, because at that time most people were trying to extirpate the membrane and debride it essentially. So I asked him about that, and he said that, well, he used to do that, but one time he was just so rushed and he looked at that membrane and it said it reminded him of a nail bed. And so he just put the graft in there and closed, and that's kind of history. So it's another one of those serendipitous things where the intention really wasn't to maintain the membrane, it was that there wasn't time enough to take it out. So the results there. So it happened then that there was a sort of a coincidence that this method of Mascalais converged with this way to accumulate large amounts of autograft. And along with this, though, with people starting to use the technique more, I would hear this observation a lot, and that was, well, it's good, but you're really washing away all the good stuff. And we know that we're washing away the good stuff when you look at this and it's all kind of white and it looks kind of anemic and maybe not very potent. And then you go to the wastewater, if that's the right term, and find out that there are all of these cells that end up. And this was a nice study that was done by the Harvard group. They couldn't get the RIA through their IRB to use it on fracture patients because there's no evidence at all of what it would do with a fracture. Would it accelerate healing, impede healing? Did it make no difference, sort of thing? So they had to come up with a study that could be done on fracture patients where they didn't have to worry about the fracture healing. Of course, that turns out to be a hemiarthroplasty. And that then pushed them to a group of patients who were much older. And they really didn't expect to find much in this older group of patients, but they were quite surprised that in a population that were expected to really have a few of these progenitor cells, they really find there's a significant number. So we know that we are losing cells from that graft material. This one done by the group out of Leeds, where they compared the hip aspirate to the number of cells that are in the waste container, and find that you would need a liter of iliac crest bone aspirate to equal the number of cells that are just being poured down the drain. So the question then is there any way to try and capture all of these cells, but what do you do with all the volume then of this water? So we've been after this for years, and I think they're really on the verge of it. It was just presented at the ORS just recently. And I found this person by the name of Phillip Kregor that is an expert in capturing stem cells from cord blood, and he has this way of centrifuging them. And so there's a modification of that device, and as they've just reported, they are now been able to reduce the volume 42-fold and still keep the capture of these cells very high. So it's beginning to look a little bit like the dog is going to catch the car, and then the question is going to be, what do we do with it? Is it really going to turn out that this huge accumulation of cells really does have some great benefit that we're hoping for, or is it not so good? So that's the next phase of this to be looked at. So you keep coming back to this thing, though, about this washed material and what effect does it have. And early on I found this paper where they had taken cores from femoral heads and they'd done absolutely no cryopreservation. They just throw it into the deep freeze and then they bring it out as much as 40 months later. They mince it up into tiny little pieces, and then they either soak it in collagenase or they don't soak it in collagenase. And then they culture. And as they say, they were surprised to see that the cell outgrowth actually occurred more quickly from those cells subjected to the collagenase wash. So I'm kind of like, well, this is now getting so much more wash than RIA and no cryopreservation and such, and yet it's still growing out cells. And then more recently, this study out of Heidelberg, where they take the RIA material that you can see, and they either just take it and freeze it before they put it into the mice, or they take it in through a collagenase wash and then implant it into these skid mice. And what they found was that the more washed the material was, the more bone they actually grew in the mice. And it's going into this issue about the whole washing thing. When this came out early on, they were showing that you could take the curetting versus the reamed, acetabular reamed heads and see a considerable difference in the amount of outgrowth from the material of the cells, whether they'd been taken with the curette or if they'd been taken with the reamer. But the part I could not get my head around for the longest time was the fact that they're trying to see how many cells they can get out of a known amount of bone. So what they're doing here is they're taking that same bone and they're washing it extensively, and then they're replating it. And they're doing that repetitively. So the cells that are coming out obviously are in the washed bone. It seems a little bit like a Frankenstein sort of an effect to me. When Thule did the paper with the curetting versus the reaming, the presumption was that the reason they saw more growth out of the ream versus the curetted was because of the fact that they created a difference in the particle size. But now there's this paper that was just published that shows that they compared the RIA material taken from the femur versus using a curette from the femur. And that the difference in the amount of cells that they would grow out was different, and they now say that they've provided evidence that the harvest procedure and not the type of bone tissue determines the osteogenic capabilities of the stem cells in vitro. So there's this question then, is it not just the site, but is there something about the harvest method and the aggressiveness of the energy that takes the graft and it has on the cells therein? When we began this whole thing, the idea was really that cortical bone was nice. It was there. It's an opportunity. But just how great a source of material really is it? And it's interesting to see that now that the way that the scientists get the stem cells is they take these mice and skeletalize the long bones. They chop off the metaphyseal ends, and then they multiply flush the medullary canal to remove all the hemopoietic cells. And then they're left with these little tiny chips of cortical bone. And they show that when you take the bone from the cortical bone versus the bone from the marrow, that there's a substantial difference in the number of cells that you get from the cortical bone. And we see this when we look at the slides, that when you look at the little particles of bone after they've been in culture for just a little bit, the first thing you see are all of these little round cells that sort of just festoon the bone particle. And an example of it would be here, the first or second day after plating, there are all of these tiny little round cells that have not been characterized. And then after some days, they begin to become these fusiform type cells that everybody associates with being the stem cell. And study after study will come back to this point, that these cells emerge from the bone. And in this one from Germany, where she says that interestingly, the bone fragments kept culture for 6 months were still a source of outgrowing cells. So the surprise for me in this whole thing has been that it is the bone itself, the matrix itself, that is the source of the bone cells. And I thought I was really on to something with this, and I showed some of this to this Jan Nolte that runs the California Institute of Regenerative Medicine. The state has two of them, one at UCLA and the other one at UC Davis. And I thought that the observation was great. She excused herself for a few minutes, came back with something that they had published in 2006. And what she's saying here is that when they do they're trying to get the stem cells, and they do the aspirate, and then they spin it down, and they get the buffy coat, which everybody thinks is where the place that they need to go to. She says it's really not a great source, but it's what most investigators have to work with. But she said that when your needle goes in to do your aspirate, you're going to end up finding some little bone spicules that are sucked up, and they'll end up in the screen. So if you really want to find the stem cells, find these little bone spicules. And she had pictures, once again, of these little round cells coming out of the bone spicules. So something some of the people have been aware of for some time. And there seems to be a shift now from looking at just the bone marrow-derived stem cells to the cortical bone stem cells. In recent papers here, they're saying that the cortical bone stem cells really, when compared to the bone marrow stem cells, are bigger in size, show a lower proliferation rate in these early passages, a greater commitment to the osteogenic lineage. And I'm not sure how this nitric oxide thing, but they call it out as important, in that they more readily respond to these pro-inflammatory cytokines, and that the cortical bone stem cells really are a superior candidate in the development of new strategies for bone repair. The cardiac people have really taken this up. They've had kind of disappointing results with a lot of their stem cell work as they try and restore cardiac function, and they've now shifted more to looking at these cortical bone stem cells to improve the survival, cardiac function, and attenuate remodeling, which they believe occurs through the secretion of these proangiogenic factors that stimulate the new revascularization and the differentiation into these adult myocytes and vascular cells. And they have several papers that are very, very recent to that point that say that the cortical bone stem cells are unique from the cardiac-derived cells, and the bone marrow stem cells possess enhanced proliferative survival lineage commitment capacity that could account for the enhanced protective effect after cardiac injury. And then finally, the last example of this and where they're going is they take a pig and they cross-clamp the left anterior descending. They leave it on for 90 minutes. This is after they've accumulated all their baseline values. Then they either give them a injection of just saline or these cortical bone stem cells into that zone of injury, and they find that in the ones that have not received the cortical bone stem cells that they have decreased their ejection fraction by about a third, the ventricles swollen by or dilated by about a third, and that their pumping function is off. And they say that the group that had the infarction plus the cortical bone, the stem cells, had no significant change. So maybe we're actually getting somewhere, and the reason I'm bringing this all out is from the time that Eric and Tim made these educated guesses about maybe this reaming material of cortical bone might have a good basis for clinical application, we're really a long ways down the road. But what are they? We really still know exactly. I asked the fellows in Frankfurt if they could maybe get a picture. This might be a mugshot of one. It's about the right size. That's a desiccated RBC right there, so you can get an idea of the size of it. And there is this controversial theory that there are stem cells invested into all the tissue, and they're just waiting for some sort of a shock to be awakened. And maybe that has something to do with what we're seeing in the differences between taking it with a curette or taking it with a power tool. So what are they? We don't know, but the investigation is certainly taking us to very new places. And I think that the answer to why bone graft works, that OIA started way back in the late 1800s, getting closer and closer to being discovered. But what about this other thing that really introduced the whole RIA into the equation, and that's about embolus? Is there still a story there? And I think it is, and I'll go very quickly. We've all heard or seen about these cases where somebody ends up with material in their brain. They do an extensive workup, and there's no patent foramen. So their question really is, how did that person end up from that intramedullary procedure with product in their brain? I found this that is quite interesting about how the fat can work its way around in the system. So what they have done is they've shocked or bled these rats to shock and then resuscitated them, and then they give them a tiny amount of intramedullary fat into their cava, and some of the animals don't like that very well. The ones that survive, they get a little bit more. And what they have done is they have drilled a hole through the skull, and they've put this video microscopy right down to the brain. And about 4 minutes after they've injected into the cava, this is what they see in the brain. And it's interesting to see how these little globules can run around and how they can come to a bifurcation, and then kind of like sort of the Yogi Berra thing, you know, when you have a fork in the road, take it, which they can do very easily. And you can see some of the spasm that it produces in the vessel, and then it shifts to another mode here, and we can see the circulation of these little fireflies, if you will, around in the brain. And if you look for some particular reason down in this corner, I don't know what it is about that little artery right there, but for some reason it just seems to accumulate it. So does the brain tissue just beyond that supply mean anything or not? Who knows? Could you discover it? So the idea then was that they then looked and found fat in the lung. They found fat in the brain, but there's no patent foramen. This is a meeting of Andy Lovering. Andy runs the respiratory physiology laboratory at the University of Oregon, which was set up by Nike. It's no coincidence that Phil Knight is an alumni of University of Oregon and decided to spend his money on this laboratory. So why should they be interested in this? Well, this is really the essence of doping. And that is, how can you improve the oxygenation of a person? And how different is the oxygenation from one person to another person? So they really look at how things get through the lung. And what they did was they took these 11 subjects, young males. They had to exclude 4 of them because of the fact they did have a demonstrated PFO. Then they use this labeled albumin, and the particles are so large that they can't go through the normal vascularity. There has to be a shunt for these to be able to get onto the other side. And then they do this whole body scanning with a gamma camera. And in the first pictures here, the lung is doing just what everybody thinks it's going to do. You can see that it's captured these globules, but you bring those same subjects back a few days later and you have them exercise really hard, put them in front of the gamma camera again, and there's the material through the lung and out into the body. And as they say, the lung is not a filter, it's a strainer. Why is that important? Most people think that the only way that you can get intramedullary product into the left side is if there's a patent foramen. But this study was done in Serbia, where they had 52 subjects that had died with an orthopedic injury, and then they look at them for whether or not they have a patent foramen or not. Now, there's no, they have the heart in their hand. They are probing the fossa ovalis. So there's no question about whether or not they do have a sealed foramen or they don't have a sealed foramen. And what did they find? Then they graded the amount of fat in the lung into these 3 grades, and then they used the index organ on the arterial side to be the kidney. And what they found was that PFO does not play an essential role in developing the lung fat embolism in these patients that had pelvic or long bone fractures. So what that seems to say is if you can reduce the amount of fat that gets to somebody's lung, then maybe it ought to be considered. And we had a study over in Norway done by Elizabeth Husseby, and they used a traditional reaming device, which in this case was a Bix-cut reamer. It was one of the new generation with a small shaft and deep flutes. But the animals had to survive 72 hours to be included in the study. Unfortunately, 2 of the animals in the traditional reaming phase died and had to be taken out of the study. As Elizabeth said, they had a severe response to the reaming. None of the animals died of PEs after using a suction irrigation system. We don't have much really on the clinical side on this. This is one of the close ones we have done in Alabama, where they used echo and had 20 patients, and they either used a suction irrigation device or used a traditional, and they found that there was a statistically significant difference in the amount of fat presented to the lungs using the RIA versus a conventional reamer. And as I say, there really seems to be not very much work done on this, and when it is done, it seems to end up being published in places that doesn't get a big readership in the orthopedic community. This was published in Circulation. They had 42 femur fracture patients that they're looking for what they call a right-left shunt. 14 of the patients they decided had a right-left shunt based on the amount of material that they saw with the transcranial Doppler. 7 of those patients developed neurological symptoms, and all 7 of those were positive for a right-left shunt, and 2 of the patients had a drop in this NIH health stroke scale of greater than 2 points associated with focal signs. This is going to be published just next week in JBJS. The study took years and years to get done out of Wake Forest. It was done by Anna Miller and Larry Webb. And what they did was they had dogs, and the dogs were in 3 different groups of whether they used a reamed bilaterally, an unreamed technique bilaterally, or did they use this suction irrigation device bilaterally. And then they put an EDAC monitor on the carotid and another on the jugular, and they took the brains after the end of the procedure and fixed them. They took 21 centimeter slices and then sliced those into 50 micron slices, and then they stained them for this hypoxia-inducing factor or heat shock protein, and also then looked for fat globules in the brain. And they find that the RIA the group had significantly smaller number of the large emboli, and that this examination of the brain confirmed the presence of particulate emboli. This is in the brain, as well as an upregulation of stress-related proteins and the hypoxia-inducing factor. So this is, so far as I know, is the first study that really shows when you get into the canal and you do things in the canal, can it end up in the brain? It seems to. So leave you with one thought, that it's really not ignorance that prevents discovery. It's the illusion of knowledge. And so I guess I'm trying to make a plea for stay ignorant. I know I can. Thank you.